Great. So this segment is about assessment of thyroid cancer. My talk is going to be very brief for 20 minutes. It's mainly for clinical and biochemical assessment. Yeah. Good. Let's try to be attentive. You're allowed to snooze a little bit, but not too much, particularly not in groups. Okay. Good. Great. So thyroid lumps. Focused history is very important. Onset, duration, progression, and symptoms related to pressure, like dysphagia, dyspnea, hoarseness, and weight loss. Particularly, the age is important. Less than 20, greater than 60 or 70. Those are the kind of important points in terms of consideration. But I want to focus on a few important symptoms, like according to the literature, 60% of the patients do develop dysphagia, but most of them not related to the thyroid. That's the important thing. To have a thyroid, to have a dysphagia, it should be more than 3 centimeters. That's what it shows. But many of them, they do have reflex symptoms or other associated esophageal problems and other things. And they do have a global sensation. And the next important symptom is dyspnea. The patients do develop dyspnea, like lying on the flat. They do develop some breathing difficulties, but you need to differentiate that from the stridor. If it is a stridor, that's a serious sign. It means the tumor is infiltrating into the vocal cords, or tumor is actually involving the trachea. Then it is causing a significant problem. But this slow-growing goiter, long-term goiters, can cause breathlessness while on exertion or lying down. So that is the key point while differentiating these things. When focusing on history, it's important to get more history about the previous thyroid, cervical, carotid, or esophageal surgeries, or even parathyroid surgery, because they do develop a complication sometimes that results in vocal cord palsies. And also assessment of the thyroid surgery. When your thyroid surgery is generally causes one of the common cause is kind of hematomas and bleeding. So making sure they don't have any other hematological problems and anticoagulations, and this history is crucial. Last but not least, the vitamin D and calcium is one of the post-op complications. So whether they have any other disease which kind of affect calcium metabolism in the body, which is important, like gastric bypass and celiac disease and other things. So when coming to the risk factors, this is one of the important slides. Any previous neck irradiation in childhood, the more the years from the radiation, and that is more the risk goes up. Previously, even the benign conditions being treated by radiation in childhood can impose a significant risk factors. And endemic goiter in certain areas, and lymphoma, asymmetric thyroiditis, which is autoimmune thyroiditis, one of the risk factors. Family and personal history of thyroid adenoma. Some of the syndromes like Dicer and Cowden syndrome, which has got some anomalies that can predispose to thyroid malignancy. And family history of thyroid cancer, we will discuss during our further talks. And in fact, obesity is one of the risk factors according to British thyroid guidelines. So the thyroid examination, whether it is small or big, it has to be systematic. You can't skip any corner or you can't jump any corner. So it's sometimes you think it's not necessary, but I've been caught in certain examinations. So it's a simple basic things: inspection, palpation, inspection. We missed the scar, previous thyroid surgery scar. Patient might have had this operation 30, 40 years ago in a different areas. They may not have any documentation. And so that's a simple inspection. It's important. And further palpation, more you're focusing on the thyroid as well as the lymph nodes. So the thyroid, whether it is mobile and whether is it really thyroid lump, or is it something else, or is it thyroglossal cyst? And on palpation, the most important thing is the lower extension. I will explain this later. And signs of pressure symptoms like dysphagia and dyspneas, and last but not least, the vocal cord function. So they need a formal vocal cord function assessment through flexible endoscopy. So once you've done the examination, you're just moving on to some investigations. So a lot of GPs are attending this conference, actually. So what tests they need to do? Do they need to do TSH? Do they need to do other TPO or other scans and all these things? The recommendation from British Thyroid Guidelines, they all should have minimum TSH. That's the kind of first investigation they need to have, no more than that. And some basic points, it's unusual to have hypothyroid patients to have a cancer, but again, that's not a golden rule. They do have cancers as well, hyperthyroid patients, but it's rare. But most of the patients with the thyroid cancers are euthyroid. So the next investigation is ultrasound. And the reason is ultrasound is more sensitive and it's a gold standard. It's the freehand FNAC is not advisable, and it helps us to grade. And also it facilitates cytology grading as well. Do we need to do calcitonin? It's not routinely necessary as a first initial screening, but it may be necessary as a cancer follow-ups. Thyroglobulins, do we need to do initial stage? No, it's not necessary. And only it's used for certain diagnostic tests as well as cancer follow-ups. Thyroid peroxidase, TPO antibodies may be used if you suspect autoimmune thyroiditis. And thanks for Professor Nick. And the NICE guidelines clearly shows you don't need to do routinely radioisotope scans for initial diagnosis of thyroid cancer. There is some value in it if there is a toxic thyroid adenoma. So in this summary, TSH is mandatory. Rest of the other tests are not really as a first line of investigation apart from the ultrasound scan. So further statements from the British Thyroid Guidelines, a thyroid function test should be requested by the GP, and euthyroid patients with a thyroid nodule may have the thyroid cancer, so should be referred to MDTT. So if they have a hyper or hypothyroidism and a nodular goiter without any suspicious features, should go to endocrinologist. So that's what a British Thyroid guideline shows. So when the GPs or primary care physicians manage themselves, it's very clear. It's a long-standing goiter, not changed over years, and previously investigated, and those cases can be managed by GPs alone. And the size, they're talking about asymptomatic nodule, less than 1 centimeter, incidental finding, no associated adverse features, can be managed by GP alone. Some patients need to be referred urgently. Some patients can be referred non-urgently. For example, if you look at this, sometimes sudden swelling with a pain, likely to be bleeding into the cyst, they can be managed, referred non-urgently. The main focus on urgency. The urgency comes with the risk factors. The risk factors are any hoarseness, we knew that, vocal cord palsy, thyroid nodule in the child, that's a high risk factor, and lymph nodes with a thyroid swelling, rapidly enlarging mass, particularly important for anaplastic thyroid cancer and lymphoma. These patients need to be referred 2-week rule. If they have a stridor, particularly on the same day, needs to be referred. So the malignancy suspicion, as I said earlier, less than 20, greater than 60, male sex, dysphagia, dyspnea, and previous radiation and previous history of thyroid carcinoma, fixity, and the painless mass. That's what you need to focus on the clinical examination and the lymph nodes. Sometimes you may not need to do any investigations or any further interventions if you think age and comorbidities and the risk is worse than the benefit. and it has not changed over years, no suspicious features, and to some extent toxic multinodular goiter without any suspicious features. Some points about the Hashimoto's thyroiditis. It's a painless, diffuse mass, particularly young women with euthyroid or hypothyroidism, with antibodies positive. Think about Hashimoto's thyroiditis. On the background of Hashimoto's thyroiditis, any rapid enlargement, think about lymphoma. Some clinical pictures. This is clear enlargement of both lobes of the thyroid with involving isthmus. I could feel the lower end. And this is one side on the right-hand side. The other one is on the left-hand side. And particularly, I put this slide because if you look at this patient, I examined this patient, and the ultrasound showed 6 by 3 by 3 centimeter mass. So I thought this mass is in the neck, and I opened the neck, but all I could see is a dome, and the rest of it is going all the way down. So how to ring Omar Hilmi to rescue this case, and this patient was transferred to Glasgow. Then further examination showed as a large mass going into the chest. So sometimes if you can't clearly get the lower end, the ultrasound is not done by proper sonologist who knows exactly, and that can cause a problem. If you look at the CT scan, you can see that this is that is the only portion you see in the neck. Then most of the portion, the next picture shows in the intrathoracic with the compression of trachea. And this is a full picture which shows a significant involvement of the retropharyngeal area. So sometimes you see the simple nodules on both sides, one large nodule on one side, a multinodular goiter with a small extension into the retrosternal goiter, or single nodule, or sometimes asymptomatic, non-palpable nodules in the neck. This is what I meant fixity. Fixity, it's very hard mass infiltrating the strap muscles and thyroid cartilage, laryngeal cartilages, or surrounding structures. That is a hard sign. Is it pause? Allah. How long is it pause? Is it all the time? Yeah, so it is clearly a vocal cord palsy, which is a clear a sign of malignancy or pre-op palsy secondary to previous surgery. This is the infiltration. You can see the tumor infiltrating into the cricoarytenoid joint and vocal cord nerve. That is, you can examine this patient as well, or can predict these things before surgery. Extensive lymph nodes on both sides, and that needs to be examined as well. I won't be there at all. I'm not sure that's probably like over. Is it very far or I don't think so. I don't think so. The other thing is breathing. You can breathe very well. I feel I'm not getting enough breath in when I'm walking. Brilliant. So this is clearly a long-standing multinodular goiter with a small focus of papillary thyroid cancer in that. But if you look at this airway endoscopy view, and the trachea is kind of collapsing, and that is you can see the anterior and posterior wall of the trachea is almost meeting the midline, and that is a clear sign of tracheomalacia. These patients do develop problems during and after, even before the surgery. These are the scans. Sometimes when you do the endoscopy, you see that the whole pharynx is pushed in the front as well, and they do develop sleep apneas and other issues as well. So medullary thyroid cancer, pretty much same clinical findings in history, but in addition, they do develop endocrinopathies. That means loose stools, vasomotor flushing, and family history of similar condition has to be examined or needs to be like clear history, which includes unexpected death, which is a sign of occult pheochromocytoma. That's one additional points with the medullary thyroid cancer on the history and examination. So thyroid lymphomas, which is again rare, but they present with a rapidly enlarging smooth mass with acute airway compromise. Sometimes the differential diagnosis ATC, which is predisposition by Hashimoto's thyroiditis. Scan shows again narrow airway. This is an interesting sign. If you look at this, when the patient is raising both arms, watch the color of the face, and the patient also getting some more breathlessness. And this on the right-hand side, you see the picture before and after this event. It means, and also you can see some dilated veins in front of the chest with this hard fixed mass in the thyroid. So it means this patient is actually developing thoracic outlet compression syndrome. So this patient, once they kind of drop down the arm, you can see the face is kind of, the congestion drops down. So this is called a Pemberton sign, and in this patient, unfortunately, developed anaplastic thyroid cancer. It was infiltrating the superior vena cava and IJV and other areas, including the trachea. So some of the differential diagnosis includes thyroglossal cyst. Brilliant. So thyroglossal cyst, it can be a small lesion, or it's a mass around the region of the hyoid. It moves with the swallowing. In addition, it also moves with the protrusion of the tongue because it is attached to the tongue base. So this is an X-space infection. This is not a thyroid lump. And this is a sebaceous cyst. And it's very superficial. This is a right level 2 neck node. It's more like a commonly caused by SCC or oropharynx, but sometimes you do get in the thyroid lump as well, with metastatic neck nodes, small nodules in the thyroid. And this is branchial cyst or cystic metastasis in the secondary neck node. And this is it is a TB lymphadenitis, like cold abscess. So I think in summary, thyroid examination and clinical history taking should be specific, focused, more focused on personal history and the family history, and also pressure symptoms and other possible cause like medullary thyroid cancer or lymphoma or anaplastic. These are the things you kind of keep that in mind and focus your history according to that cancer. And systematic examination, which includes signs of hyper or hypothyroidism, whether the fixity, lymph nodes, and vocal cords. And basic investigations, TSH to start with, then ultrasound guided FNAC. That's the kind of basic as a starting for thyroid history and examination. I'm happy to take any questions. And there's some questions there. Okay. If you have any questions, you can put that in the chat. Any questions from the audiences here? I think that's fine. They're asking, do we need to do CT in all cases? Omar, do you do CT in all cases?
No, we don't routinely do a CT scan in the evaluation of thyroid nodules. The only time that we would routinely do it is if there was clinical evidence of metastatic disease or radiological evidence of metastasis on the ultrasound, or if the case you identified where you think this could be significant retrosternal extension. But cross-section imaging isn't routinely required. Ultrasound and clinical examination is enough.
Absolutely. Okay. What is the value of measuring the TSH?
Yeah.
Happy for you to answer the questions.
If it's suppressed, then you've clearly got a potential for that patient being thyrotoxic. And that's one of the few instances where we would consider doing a technetium scan, because if they've got a toxic adenoma, then clearly toxic nodules are less likely in adults to be malignant. You would go for a hemithyroidectomy that would both treat the toxicity and also diagnose the condition. If they were toxic and it was a generalized uptake, well, then they've got thyrotoxicosis for another cause, and you would consider doing a total thyroidectomy rather than a hemithyroidectomy. But this is not for cancer.
Okay. If any patient came with a thyroid lump less than 1 centimeter with thyroids 2, but had on palpation, is it necessary to undergo further investigation in this, like FNAC, to rule out malignancy? Great question, though. Yeah, Professor.
Can I make a comment about the TSH? I mean, it's patients with a lump go to their GPs, and their GP's instant reaction is to do thyroid function, and it's normal. So, and quite often they will then discharge them or say nothing needs to be done. And it's a number of times I've heard somebody say, "Oh, I had my thyroid function checked a year ago and it was normal." So there is a sort of a wasted, you know, it's almost as it's not really it should be ignored, but it can actually distract from the real diagnosis. So I think one has to be careful about that.
Yeah. Good. Thank you. That's less than 1 centimeter on palpation, undergo further investigation. The answer is yes, actually, if there is any abnormal features. If there is no abnormal features, I don't think they need to investigate. What do you think?
I agree entirely with you.
Yeah. And is in a suspected thyroid cancer with METs, do you do contrast or non-contrast CT scan? I think maybe I'll leave that question to the radiology talk. Just wondering whether there will be recordings shared eventually later. I can't promise, but I'll try my best. Indications of a thyroid scan. Omar, do you want to answer this, or do you have answers in your talk? Indication of thyroid scan. Yeah, I think there is a radiology talk. I'll leave it to that. I'll take questions only on examinations. My talk is more preliminary, basic talk. Great, thank you. I think who is the next speaker?